Thank you all for having me here today. Volume okay on this microphone? Is that close enough? Okay. So today what we're going to do is try to talk about cholesterol control. There's a lot that has happened recently, but a lot of the information we're also going to talk about is how it fits in with old information that we know that we should all be doing. So before we get started, why don't we first just talk about what is cholesterol, because that can sometimes be somewhat confusing. Cholesterol, well, first off, let's back up into food. The food that we're eating is made up of various nutrients. There are carbohydrates, proteins, fats, and then there's the minerals and vitamins that make up our food. Within the fats, we often consider or discuss them as saturated, unsaturated fats, and that has various types of names that go along with it, including cholesterol being one of the trans fats. But when we measure cholesterol in the lab, when you go to your doctor and you get a cholesterol profile, we're not actually measuring necessarily the cholesterol molecule per se. What we're measuring are a group of molecules that are called collectively lipids. And these lipids combine with various proteins and have different shapes and structures that we call lipoproteins. And they can have these very large size molecules that are what generally get absorbed when you first eat a fatty meal. And then inside the body and the liver, there are various changes that occur that kind of change the shape and the makeup of these molecules, so that we commonly talk about the two most common ones that we talk about are the, oh, I'm sorry, I'm going the wrong direction, HDL and LDL. Those are the two most famous lipoproteins that we talk about when you go to the doctor or when you're trying to regulate your levels. So is cholesterol bad? Well, it must be, because I guess we wouldn't be having this talk today. But actually, cholesterol is very important. You need cholesterol inside your body. It gives support to the cell membranes that allow them to be soft, to keep their shape, for cells to move around without breaking apart. But also, there are several things that are present in your body that could never be formed without cholesterol. For example, some of the hormones in our body, the bile acids responsible for absorbing some of the food that you eat, and vitamin D are all made up from components from cholesterol. But obviously cholesterol has a bad side to it. And so back in the 1990s, there were some publications that looked at various studies that linked together higher cholesterol values with the development of heart disease and heart attacks and dying from heart disease. And so what we see is most of these studies have shown that as you go from a low to a high cholesterol level, total cholesterol level, there's a greater link. So how does that play in with the development of heart disease? Well, it turns out our bodies have these arteries that flow throughout. They carry blood to the heart, the brain, the legs, the muscles, your intestinal organs. So when we speak of heart disease, really what we're talking about is the clogging of these arteries that supply blood to the heart muscle, the body muscle, and the organs. And this slide may be a little bit small to see, but the process that's occurring is that there are injuries that occur to these blood vessel cell walls, and as a part of the healing process, cells move to these areas of the blood vessel wall, and those cells often will suck up or absorb the cholesterol that's floating in the bloodstream. And it turns out that if cholesterol has a certain makeup, these lipoproteins have a certain makeup, they're more likely to get absorbed into by these cells, ultimately creating a collection that forms these large plaques that become, in the beginning, very soft and are very prone to rupturing. And it's when they rupture that they release their contents into the bloodstream, and that creates a coagulation response that clots off that area, that blood vessel. And that's what typically a heart attack is. All right. So how can we lower our cholesterol to avoid having heart attacks and strokes and heart disease issues? Well, probably the cheapest, the easiest, the best way to do that is modify your diet. And in fact, if you are able to become a vegetarian, there has been some research that has shown that that is one of the prime diets that was shown to actually reverse heart disease. Not only just slow it down, but reverse it. And there was a study in California looking at a group of it's around 50 patients, and half of them became vegetarians and half of them just ate a regular diet at the time that was felt to be correct. And in all the patients who became the vegetarians, their heart disease, by looking at angiograms a year later, actually showed that their blockages in their heart arteries had decreased in the majority of the patients. So becoming a vegetarian works. Unfortunately, it's tough. It's hard to live in this world and become a vegetarian. There are two other diets that have been proven to be beneficial with reduction of heart disease. That's the Mediterranean diet and the DASH diet. We won't go into the makeup of those diets here on today's talk. That's quite complicated on the actual ins and outs of it. But those are the three proven diets. All other diets that help you lose weight or do certain things do not necessarily reduce heart disease risk. The second thing you can do is exercise. Now, you don't have to join a gym. You don't have to go jogging and become a world-class athlete. But brisk walking has been shown to be beneficial. In fact, in that study I told you about in California, one of the things they did besides becoming vegetarians is they just went on a brisk walk every day. And so that has been proven. But if you're capable, a treadmill, a bicycle, if you're not able to walk, steppers, dancing has been shown to be very beneficial, or any sport activity. Third thing, and this is probably the toughest, maintain a good body weight. Obviously, that goes hand in hand with if you have excess calories and you're eating foods that are very fatty and high carbohydrates, then you're going to gain weight. And so clearly there is a connection between maintaining a good body weight and maintaining good cholesterol levels. And then there's, if you, certain medical conditions, if you have them, work with your doctor to have them treated properly. So for example, diabetes, low thyroid conditions, kidney disease, liver disease, those all directly affect your cholesterol levels in bad ways. So it's important to make sure that they're being taken care of properly. Next, not smoking. Hopefully no one here smokes. Unfortunately, our younger generation is still getting misled into smoking, and so smoking has not completely gone away. But one of the common things that I hear, well, doctor, I don't really smoke that much anymore, or I've cut back. Well, unfortunately, cutting back has some benefit, but whether you're smoking more than 15 cigarettes a day or less than 15 cigarettes a day, as you can see, the risk of having an MI is not much different. So it's either you smoke or you don't smoke. And if you do smoke, stopping is the most crucial thing you could do. And then finally, and this will be the majority of the rest of this talk, will be medications. So assuming you're not going to go through with all those other previous recommendations, then you're left with having to take medication to help correct your cholesterol problem. And so there are various classes of cholesterol medicines over the years. Some have kind of become popular and then gone away. And we'll go through each one of those very briefly. But before we do that, who needs cholesterol treatment? I mean, because not everybody needs to be put on cholesterol medication. Well, it turns out that over the years, our thinking has changed. And more recently, what we found out is there's some good information that says if you fit into certain categories, then you should be on treatment. And if you don't fit in these categories, you don't need treatment. So if you have any of the following, you've had a heart cath that has demonstrated blockages in your heart, or you've had a heart attack before, or it's been shown that you've got blockages in any other blood vessel of your body. So for example, in your legs, your kidneys, your arms, your neck arteries. If you've got any of those arteries with blockages, then you're in this high risk category. If your cholesterol level, the LDL level, is above 190, you'd be considered in a high risk category. If you have diabetes, you'd be in a high risk category. And the other is if you have a heart risk rate over the next 10 years of excess of 7.5%. Well, quite honestly, that's kind of hard for you to figure that out on your own. You'd need your doctor to help you do that. But basically, there have been research studies that have put together the collection of your age, your sex, whether you smoke, whether you have high blood pressure, and what your cholesterol readings are. And from that information, you can predict someone's risk of having a heart attack or stroke in the next 10 years and for the rest of their life. And so that calculation, you can go online and also find calculators that'll help you do that, but it's not straightforward to calculate. But your doctor can calculate it. And if you are in that high risk category, then there's really only 2 medications that have been shown to be beneficial and that are considered the medicines to take. And that would include atorvastatin at the 40 or 80 milligram dose, or the rosuvastatin, which is at the 20 or 40 milligram dose. Atorvastatin used to be called Lipitor. Rosuvastatin used to be called Crestor. They're now both in generic, and that helps bring the cost down and make it much more appealing to patients. If you meet any of the next criteria, if you've got a family history of heart disease, premature heart disease, and this is something that's commonly misinterpreted by people. Premature heart disease is considered when your mother or a direct relative has a heart event, such as a heart attack or stroke, below the age of 55, or a man below the age of 45 in a father or son or brother. Your cholesterol, your LDL cholesterol, is between 160 and 190. You have a high CRP level greater than 2. Now, high CRP levels in general are not routinely checked, or not, the insurance companies often don't support that. But that information is useful when you suspect someone is at this intermediate risk and you're trying to decide whether there's justification for putting someone on treatment. And then if you've ever had a CT scan that looks at the calcium inside your heart arteries, called a coronary calcium score, if that level is 100 or higher, then these would all put you in a medium risk category. And if you're in a medium risk category, the only drugs that have been shown, or the current drugs that are recommended for treatment, would include atorvastatin at the 10 or 20 milligram dose, rosuvastatin at the 10 milligram dose, simvastatin at the 20 or 40 milligram dose, pravastatin at 40 to 80 milligram dose, and lovastatin at 40. Okay. If you didn't hear your name called in that list, those 2 lists, then you're in the low risk category. So everybody else low risk, there is no proven benefit that putting you on cholesterol lowering drugs will make a difference. Okay. Now, guidelines are published every so often by the experts in the field, and they kind of, it seems, each time change our thinking about this. And some of the highlights from the most recent guidelines, in addition to what I just told you about high and medium risk patients needing treatment, the other one is cholesterol levels in the office. It is not uncommon to see patients who have their cholesterol levels checked every 3 months, every 6 months, or yearly. Well, there's actually no research that shows that makes a difference, because with the current thinking, once you decide someone's either high risk or medium risk and you need to put them on treatment, then you put them on the proper treatment. And once you do that, there's not another treatment beyond that that has been shown to make a difference. So routine checking is not recommended by the experts. Now, I'll tell you that we can all come up with a couple scenarios where that information would still be relevant and we would still want to check it. So I'm not going to stand here and say I don't check cholesterol levels after I put somebody on it. But routine checking, just to check it and you're doing well, there's very little benefit in that. But each visit with your doctor, the risk should be reassessed to see if you've gone up in risk. If you were previously in low risk or mediate risk, there may have been new factors that put you in high risk, and that would warrant changing your treatment. Okay? So when we talk about, if you notice, the only medications I've recommended so far, based on these expert opinions, are statin drugs, if you didn't recognize that. Turns out there are all these categories of cholesterol medications, and you can see on this slide drugs like gemfibrozole. Oops. Barely lowers your cholesterol level, your LDL cholesterol level. Absorbing drugs like Zetia. Anybody here on Zetia? That's a common medication. It stops the absorption of cholesterol from your dietary intake. It lowers it by 17%. And you can see all along these categories: fenofibrates, niacin, bile acids, sequestrants, omega-3 fatty acids, statins, and then this new drug that we're going to talk about at the very end of the talk have these progressively greater lowering of LDL. And it's only the statins that lower it the most that have been shown to be beneficial. So we'll go through a couple of highlights. I mentioned Zetia. And the reason why is it only lowers it 17%. It does have one scenario where it's beneficial. Sometimes patients can't tolerate these high doses of cholesterol drugs, even though they're recommended. And so adding Zetia to one of the cholesterol statins has been shown in one trial to be somewhat beneficial, adding some benefit. And so it has a purpose still, but it's never been shown to be useful by itself. Niacin was a very popular drug for many years. Anybody here on niacin or been on niacin? So niacin was a very popular drug, and when I first came out of training, we used it like water. It seemed like we put everybody on it. And there was a lot of theoretical data on why it should be useful and helpful. But it has a very mild lowering of LDL, only about 25%. And unfortunately, the studies that demonstrated benefit only demonstrated that benefit when used at very high doses of around 3 grams a day. And if anybody knows about niacin, one of the problems with niacin is it can cause a severe flushing reaction. And the higher the dose you take, the worse that flush can be. And so it's almost impossible to get anybody to take 3 grams. So even though we know it can help a little bit, most studies have not been able to get anybody to tolerate it. And so that's why it's failed, probably failed in a lot of research studies. Bile acid sequestrants, those were one of our first cholesterol-lowering drugs. They kind of, if you recall earlier in the talk, I said that cholesterol was needed to make bile acid. It's part of the molecule structure. So by binding the bile, you reduce the amount of cholesterol in the intestinal tract, which is available to be reabsorbed and reconverted to cholesterol. And so by lowering that pool, then your body tries and grabs more cholesterol from the body to make up for that bile that got bound by the drug you just gave. And so those drugs will lower your cholesterol, your LDL cholesterol, by about 30%. But they're really considered drugs that we use as a last resort because, once again, they have side effects, they're often not tolerated, and there have not been any studies that have really shown any benefit of reducing heart attacks and strokes with them. Fish oil, kind of similar to niacin, has a lot of promise. The problem is its main use today is considered if you're using 3 to 4 grams a day for lowering triglycerides. As far as lowering LDL and reducing heart attacks, studies have not been able to show that. We've not been able to link that. And part of that may be just getting an adequate, reliable supply of fish oil. You can buy fish oil in any of the GNC stores, Costco sells it, things like that. The problem is there's not an FDA oversight. So the quality of the fish oil can vary from manufacturer to manufacturer, and it can vary from lot to lot or month to month. And so that probably explains why, even though we know it should have some benefits, in research studies it has not shown it has not reduced the risk of heart attacks. Now here's a common one that goes in fads over the years, and that's red yeast rice. Anybody use that or have tried it? You know, red yeast rice helps lower LDL cholesterol. The problem is you have to use a huge amount of it, and if you use a huge amount of it, you get the equivalent of using the smallest amount of the weakest cholesterol drug we have available. So yes, it lowers cholesterol, but at such a small amount that it ends up not making a big difference. And so that brings us to what we do recommend, what the guidelines recommend, and that's statins. Statins have been proven through countless studies to help shrink the blockages in the arteries if given at the high enough dose. It helps, if you remember that slide of that blood vessel with the plaque that was gradually causing the size of the plaque to get larger and larger. Well, that enlarging process we call an unstable or inflamed plaque. Well, statins have been shown at high doses to stabilize plaques. So if you do have a blockage, it tends to reduce it from growing and then rupturing, causing a heart attack. And here's a collection of all the research studies looking at statins and how much LDL lowering they achieved at the various doses. And what you can see is that with the greater lowering of cholesterol, there was a lowering of the heart attack event rates. Okay. It's a busy slide, but look at the line. So that's the summary of where we get research that has shown that. The problem with statins is they cause a lot of side effects, or at least in a good number of people, they claim that they cause side effects, and that's been shown. The most common is muscle aches or myopathies. But it can also affect your liver. Turns out that affecting your liver is a lot. If it's going to happen, it's going to happen usually in the first few months that you take the drug. But if it hasn't happened by that time frame, it's pretty uncommon unless something has changed in the manufacturing process of the drug. And then it can also increase your risk of developing diabetes. But the risk is very small, and the benefits of the drug far exceed that risk. So when you look at that risk of developing diabetes versus the reduction of preventing heart attacks, clearly the drug is beneficial. Now there are a couple of, whenever people do have side effects, when they have muscle aches or liver toxicity issues, one of the first things is to look to see if they're on any of these drugs that I have on this slide. Because these are drugs that have been shown to affect the metabolism, the breakdown of the cholesterol, the statin drug in your bloodstream, and so they compete with the breakdown of the cholesterol drug, and they can sometimes cause the levels to exceed where you want them, and that's what they often explain some of the symptoms. So if you're on a cholesterol drug, a statin drug, and one of these medications and you're having side effects, often just switching one of these drugs to some alternative drug may solve the problem. Within all the statin drugs on the market, this is the maximum amount of cholesterol, LDL lowering we get from each of the drugs. And as you can see, the two best are going to be a atorvastatin and rosuvastatin. There it is. And drugs like lovastatin has the least amount of benefit. This is a breakdown of the same information, but based on the actual dose of the pill. And so what you can see is with what we consider high intensity treatment, it's the 40 and the 20 milligram dose, and the 54 and the 48, which are the higher doses for the atorvastatin. Those are the 4 lowering effects that we get that we consider high intensity treatment because we get the most benefit from it, the drugs. To kind of prove the point that the higher dose is better than the lower dose, there was a research study that looked at one of the better drugs, atorvastatin, and it looked at the 80 milligram dose and the 10 milligram dose. And what you can see on this slide is over the course of 6 years, there was a significant and continued reduction in having a heart attack or a stroke compared to the lower dose. And as time went on, if you stayed on the higher dose drug, you continue to get further benefit. And that's right here. Regarding whether to take atorvastatin or rosuvastatin, there was a large study that recently concluded that looked at the two head-to-head, and there was no difference. So which one you take, it doesn't matter. They both have about the same benefits. Now, the last medication we'll talk about are these PCSK9 inhibitors. They're a brand new drug on the market. They're given as shots, subcutaneous shots. And the wonderful thing about these drugs is you don't have to give them every day. The first one on the market, you only have to give every 2 weeks or twice a month. And the cholesterol lowering with these drugs has been shown to be quite strong, anywhere from 60 to 70% lowering of the LDL. And as of right now, there are no significant side effects being reported with these drugs. They work in a very complicated mechanism. This is the slide that kind of shows that. But the bottom line is cholesterol, one of the main organs in your body that plays around with cholesterol is your liver. And so your liver kind of helps regulate the levels of LDL cholesterol. And so it's constantly grabbing the LDL, the LDL cholesterol, it brings it into the liver cell, it breaks it down, modifies it, and under normal circumstances, it will do that at a certain pace and help regulate your levels. PCSK9 molecule actually attaches to that collection of a receptor on the liver cell with the LDL receptor, and that tells the liver to break all of it down into little pieces. The problem with that is it even breaks down the receptor that's responsible for grabbing on to the LDL in your bloodstream. And so you can imagine that if you have very high LDL levels and you're breaking down one of the things that's helping you remove LDL, then in the long run, you're not going to be able to keep up. So they found out that if they can just inactivate that molecule, that all of a sudden the receptor gets immediately recycled to use again. And so now you can absorb or break down or bring in a lot more cholesterol, LDL cholesterol into the liver cell and help lower your levels. And they've gotten excellent results with that. The two drugs currently on the market, and you can go to your doctor and get these right now, Praluent and Repatha. Praluent is every 2 weeks. Repatha is every 2 weeks if you take a normal size injection. If you use this little piece of equipment that will infuse the medication over a longer period of time, you can dose it every 4 weeks. The only problem is it's $14,000 a year. So when the drugs first appeared, the companies were giving it away with the hope that the insurance companies would sign on and say, yeah, this is a great idea. The problem is the insurance companies have not bitten. And if they do cover it, then we're talking about, if they'll cover it partially. And usually they'll cover it partially, and you'll still have to pay $300 to $400 a month. So there are some drugs on the market that are more expensive than $300 to $400 a month, a lot of chemotherapy drugs, things like that. But that's still a lot of money. And its benefit is only an extra 5 to 10% over our statin drugs. But if you can't tolerate a statin drug, it may be your only choice if you really need treatment. There is a new, a third medicine that's currently in trials that's kind of getting towards the end of the trials, but we're not sure when it'll be available. It works slightly different, and because it works slightly different, it works in a way that they can reproduce at a much higher level with a lower cost. So no one knows how much it will cost when it finally becomes available, but it won't, what we're told is it won't be anywhere close to $14,000 a year. And my thoughts are that I'm sure when that drug comes available, then I'm sure the insurance companies may jump onto that one and let you use that if you need it. But for right now, the only indication for using these new drugs is if you have a very high risk of cardiovascular disease, you're in that high risk category, and you can't tolerate statins. That's one of the groups that the insurance companies will consider if your insurance company will pay for it to begin with. And if you have familial hypercholesterolemia, fortunately that's a rare condition, but people who have that have these ungodly high LDL cholesterol levels, and they have very short life expectancies without some form of treatment. So it's not available yet, but hopefully soon, and that may be the answer to some people who can't tolerate statins. Thank you.